So the next is also a very famous speaker, Professor Arun Singh, who will talk about chemotherapy in retinoblastoma. We have quite a lot of option for application of chemotherapy in retinoblastoma. And then the question is which route? 8 minutes for you, Dr. Singh.
Thank you very much for the privilege. It's always fun to be here. So in retinoblastoma, we always think of chemotherapy as the primary treatment nowadays, but we must not forget when to do enucleation, because we know enucleation is still the most common treatment across the globe, even in developing nations like United States. So it's not that the enucleation has disappeared, it's just that nobody's talking about it anymore. So my talk is therefore to emphasize the continued role of enucleation that has been used for retinoblastoma for more than 150 years. So let's talk about just general criteria. We say is unilateral group D or E disease. I think thing to focus is the vision potential. In my opinion, if there is vision potential, it's worth saving the eye, and if there's no vision potential, we talk about that, then you really don't think you can say it's worth all the effort of putting the baby or child through 30 EUAs and expensive treatments in some parts of the world. I think presence of neovascular glaucoma, extraocular extension based on imaging are also clear criteria for enucleation or modified treatment, and also to large extent the anterior chamber extension, perhaps exception being a monocular patient. So let's look at a case here. In this case, there's neovascular glaucoma, and there's no view to the disc and macula. You can see the eye is full of tumors, group E disease. No matter which classification you take, I would say that's a good case for enucleation. Let's move on very quickly to a case of when you might think primary IVC. I would say a child less than 3, because technically it's difficult to do IAC in a child that young. Patient has bilateral disease, perhaps it's better. And again, keep in mind the vision potential, groups B, C, and D, for example. So look at a patient here with a nasal tumor with extensive seeding in the right eye across the macula. The disc and macula are not directly involved. And the other eye has a group C disease. So I say this is a good candidate for intravenous chemotherapy. Both group B disease on the left eye, both eyes were treated with intravenous chemotherapy, and patient did very well. But look at the patient here, has a unilateral disease, has a vision potential because here the tumor is nasal, inferior nasal, there's diffuse seeding across the macula, but the macula is not directly involved. The retina is normal under the seeds. So it's a unilateral case, it's maybe a year or 2 years old, and there's some vision potential. We know in group D disease with the data coming out of China, in a randomized trial, that IAC is a superior primary treatment than IVC. So we chose IAC for this case, and patient did very well. You can see the tumor, nasal tumor shrinking very nicely. It's a unilateral disease, and patient recovered very good vision, of course combined with intravitreal chemotherapy, in this case mostly melphalan. Seeds went away, patient had very good vision. So again, it's not the problem is not the treatment, it's the case selection. You say IAC did not work, well, there's something wrong in selecting the patient. Look at this patient again, 12-month-old, total extraretinal detachment, but there's no extraocular extension. It's a 12-month-old child, and one could have enucleated this case, but again, parents have preferences for not having the enucleation. This eye was treated with IAC, and you can see all the complications of IAC with extensive vision loss, choroidal atrophy, and optic atrophy. So IAC may save the globe, doesn't give you vision necessarily. We say about 10-20% of cases will have severe vascular complications. So if this case was one eye had been enucleated and this is the only eye, the child is blind basically. So keep in mind that IAC isn't going to give you vision necessarily. So here's another case who is 3-month-old, has unilateral disease, and we thought IVC is okay here because the child is young, and we find in a hospital IAC is difficult in younger children, and the patient did very well. You can see that here the nasal tumor, kind of inferotemporal tumor, fell away from the macular area. But this is a case, again, unilateral disease, extensive neovascular glaucoma, filling the globe. It's unilateral, no chance of vision here. There's really no view of disc or macula. The eye was enucleated, and there's neovascular glaucoma. So, and this case had extraocular extension on histopathology and even choroidal invasion. So if there's choroidal invasion, we know enucleation is not enough. So you can choose different cases, different treatments, and perhaps give the best outcomes. But of course, you have to discuss with the family, offer them what you can, give them the rationale that you have. So why you're doing it, I think that's very important. Not just what you're doing or what you're recommending, but why you're recommending their treatment. Please tell them that. That's very important. And of course, realize that a child who receives conservative therapy on average will have 30 EOAs. Every month for 3 years or so, they'll be checked up. So think about the burden of travel costs and multiple anesthesia. It's a long-term journey. It's not just one treatment, one opinion. And of course, it depends upon the means and expertise that you have. So you can only make choices based on where you are and the choices you have. Thank you very much for the opportunity.